This is the visible.
Yes, sir. Visible, sir.
Okay. So the question is hemodynamic effects in pathophysiology of aortic cross clamping and unclamping. Okay. So this is, describe briefly the physiological changes during aortic clamping and cross clamping during vascular surgery. Which therapeutic interventions can minimize these effects? Okay. So it's usually done for surgical procedures to stop flow temporarily. So what is the difference between a tourniquet and aortic cross clamping? Tourniquet you apply for your limb surgeries, and the aortic cross clamping that you do for vascular surgery. What is the difference?
Tourniquet is usually applied to a smaller area where we need to reduce the blood supply, sir. But if it's the aorta, then a major portion of the body is impacted.
Anything else?
Tourniquet, we probably venous return will be decreased with aortic clamping. The
arterial and venous flow is blocked in tourniquet, isn't it? We raise it above the systolic pressure. So we block the arterial flow, we block the venous return. Both are blocked in tourniquet. And arterial flow, we block only the arterial flow in aortic cross clamping. We don't go anywhere near the IVC or the other major venous channels, isn't it?
Yes.
So that is a major thing. But aorta being a main supply of oxygen, so the areas which are devoid of arterial blood flow, they go in for anaerobic metabolism, and that is one of the reasons we develop acidosis. Okay. Whereas in the tourniquet release, we get both venous congestion as well as arterial lack of arterial oxygenated blood. So collateral perfusion distal to that should have to take care of that. To measure the reduced the agitation, the unclamping include the administration of fluid vasopressors as well as flow removal. That is the technique how we do. The indications can be for vascular surgery, cardiac surgery, or trauma. These are the indications for aortic cross clamping. And locations is very important. And the location can be intrarenal, suprarenal, or supraciliac. These are the three common locations where we try to apply the clamp: intrarenal, suprarenal, and supraciliac. So infrarenal is the most safest one because the renal perfusion will be still there and the celiac perfusion will be there. Only the blood going to the lower limbs will be blocked for a few. They can withstand hypoxia for a longer time. So for any clamping here below the renal vessels, it is always much more considered safer than the suprarenal and the supraciliac vessels. Now, three things happen. One is there is an ischemia, which is the first thing that you have to talk about. So I am giving it in a different color, pathophysiology of aortic clamping and mechanisms of ischemia. That is development because of the application of the clamp and there is no blood flow. And if it is more than 90 minutes, the ischemia is quite severe. And this flow chart tells you what happens. You apply the aortic clamp. Distal area, there is a decreased perfusion. Proximal area, there is an increased perfusion as well as increase in blood pressure. Here it is a hypotension in the distal portion. Then there is increased risk of ischemia due to inadequate perfusion. If it is suprarenal location, increased risk of renal ischemia and postoperative renal dysfunction. If it is supraceliac, risk of gastrointestinal ischemia and the postoperative liver dysfunction. So suprarenal, chances of post-op renal dysfunction. Supraciliac, chances of post-op liver disinfection. And the second thing, hemodynamic changes. What are the hemodynamic changes with aortic cross clamping? Again, this picture will tell you what happens is, first thing is there is an increased catecholamine or vasoconstrictor releases. There is a passive recoil distal to the clamp and increase impedance to aortic blood flow naturally from the heart to up to the level of the clamp. So when there is an increased catecholamine, increased vasoconstriction, both proximal and distal, and increased arterial resistance, this leads to increase in the preload, and this leads to increase in the afterload also, both in impedance to arterial blood flow and as well as the increase in arterial resistance. They produce afterload resistance increase to the heart. So this results in myocardial contractility to compensate for that, and increases the coronary blood flow, or decrease or increase in the cardiac output happens because of the balancing act of these things. So the second change you have to mention is about hemodynamic changes, which can be easily drawn with these pictures. The third thing that happens is the blood volume distribution with aortic cross-clamping. So again, you can have a passive recoil, increased catecholamine release, increased vasoconstriction, decreased venous capacitance vessel. Then blood volume shifts to proximal to the clamp. That will lead to increased perfusion in the muscles and other things proximal to the clamp. Blood volume shift into the splanchnic vasculature also can happen. All these things will lead to perfusion. Increased perfusion of the brain and lungs because of more blood flow. Increased venous return and preload. Increase or decrease venous return preload to the splanchnic area. And supraciliac cross-clamping, infraciliac, these are all the results that can result. And humoral effects, lastly, the acidosis happens. Longer the duration, more the acidosis, more inflammatory mediators will be released. Sodium bicarbonate has been previously taught as an important drug to correct this acidosis. But now it does not prevent the hypotension, it does not correct the acidosis, including because it is happening in the arterial wall. So with unclamping, CO2 levels rise due to washout of distal tissues and from increased production due to inflammation from reperfusion. The second humoral change is renin-angiotensin system change that also causes increase in the level during cross-clamping, especially suprarenal clamping. And it also increases during intrarenal clamping also for unclear reasons. Despite the persistence of hormone levels for hours after clamp removal, they have been shown to result in hypertension. Then catecholamine release, which we saw in the earlier pictures, both epinephrine and norepinephrine levels increase. And epinephrine is predominantly released during application of cross clamp, while norepinephrine is released during the clamp is removed. And sympathetic activation from ischemia and hypertension likely to contribute to these findings. Then release of reactive oxygen species, which will be causing more damage in the organ dysfunction. Phosphate, reperfusion of ischemic tissue results in increased production of phosphate containing compounds, leading to a shift in the phosphate from extracellular to intracellular compartment. So for at least 48 hours after cross-clamp level, phosphate depletion may be necessary. You may have to replace that. Cytokines and other inflammatory mediators, especially as we rightly said, fever necrosis factor and interleukin-6 are the things that are. And this TNF is very important for lung injury and after reperfusion. And aortic unclamping, again you have a picture like this, and once you unclamp that, ischemia distal to the clamp and release of inflammatory cytokines, increased vascular permeability, vasodilatation distal to the clamp, pulmonary edema, fluid shifts into the vascular compartment. All these things during clamping can happen, but once you do the unclamping, washout of inflammatory mediators from the anaerobic metabolism that has been going on in the areas, and increased pulmonary vascular resistance, decreased myocardial contractility by these washed out mediators, which causes central hypovolemia, decrease in venous return, decrease in cardiac output, and hypotension. So once you do the unclamping, you have to expect a profound hypotension. So you must be prepared. That's why always the surgeons will caution the anesthetist that I'm going to unclamp. And you have to be ready with fluids, vasopressors. So you have to tackle that very cautiously. And they also will slowly release the clamp, little by little. One it will not be done at a certain level. They will always caution you. So the main reasons for hypotension following unclamping are increasing the capacity of focal distal clamp, arterial vasodilatation due to decreased arterial resistance, and accumulation of metabolites with myocardial depression and vasoactive properties. So it becomes almost like a vasoplegia condition where the blood starts cooling all the vessels, both the arterial as well as the venous side, compared with and also depression of myocardial contractility because of the vasoactive peptides. So all these things result in the hypotension. So we have to correct all these things. We have to increase the arterial constriction, venous constriction, as well as the myocardial contractility. So preparation prior to cross-clamp removal, these are all the goals and methods. Reduce pulmonary vascular resistance, maintain myocardial contractility, reduce impact of inflammatory mediators, prevent hypotension from central hypovolemia, prevent rapid fluid release, reduce severity of ischemia. How do we do that? Avoid hypercarbia, hypoxia, and pain. Maintain initiation of iron-focused medications. Initiate vasopressors as needed. Careful fluid loading and remove clamp slowly. Consider partial or full reclamping if there is significant hypotension occurs. Target normally oxygenated blood instead of hyperoxygenated blood to decrease the free radicals. So don't give too much of oxygen at this level to prevent the decrease in the free radicals. So this is not a complete answer for this, but main points I have given. And as she rightly said, you have to mention about the spinal cord problem as well as the post-operative renal dysfunction, as well as a supraceliac. You have to include or mention about liver dysfunction also. Okay, so these are the things that I think will be useful for you to write this answer. So that flow diagrams will be helping you to mention all the points in a faster way instead of writing specific sentences. Okay.
Okay, sir.
Right.